Are we all here? Are we live?
We are live. Go ahead.
All right. Welcome everybody to it's Tuesday.
Go ahead.
It's Tuesday and it's 3:05. Welcome everybody to.
Can't really hear your voice, Doc.
Here we go. How about now? Can you hear me?
That's better.
Everybody make sure you have your YouTube muted.
Yeah, somebody had a feedback there. All right. In the comments, there's a few of you guys here, so throw up in the comments if you can hear us, please. And Peggy says can't hear.
What kind of music can we put?
All right.
Okay.
Good afternoon, everybody. We're going to get started with a little update, and then we're going to start with EPCR. So if you have EPCR questions, fill the chat with those now. Yes.
Oh, so I'll throw up the numbers to get us started, Jasmine. Yeah.
Yep. Great.
So here we go. It is Tuesday, and we have 32,846 cases in the state of Florida. We continue to see the rate at which case growth is increasing, slowing, but models are still changing. And in fact, one of the models just today increased their total number of deaths that they're predicting in the US from this. We have had over 1,100, almost 1,200 deaths in the state of Florida so far from this. And if we drill down to the Pinellas County numbers here, you can see that we are up to 709 total cases and 31 deaths, well over 200 people hospitalized. I think as of yesterday, there were still over 100 people hospitalized in Pinellas County, just over 100. Although many of those were folks that came out of nursing homes, and not all of them remain acutely ill. Some of them are just waiting placement into an appropriate facility. So, you know, our overall level of testing is still fairly low, but based on the testing that we are doing, you know, the percent positive is pretty low, somewhere around 5% or less as a ballpark number, depending on how you crunch the numbers. But it's important to note that we're still only really testing symptomatic people. So that is not the same as what is the prevalence of this virus in our community. We know something about confirmed positive cases. We know something about how many people are in the hospital with this. We know a little something about how many people are in the ICU or dying from this. But we don't really know the true, what we would describe as prevalence of the, or penetrance really, of the disease or virus into the community. And you've probably seen things from other places in the country where those numbers range anywhere between, you know, 5 or 10% of the community infected, many of whom are probably asymptomatic, all the way up to some places where they're, you know, 20, 30% of the community. So the virus is still new. We don't know as much about it as I wish we did. And our approach to it from an epidemiologic standpoint continues to evolve. And our approach to it from a clinical standpoint also continues to evolve. At the County Board of Commissioners meeting this morning, they did have a couple of motions to open pools and I think some certain playgrounds on Thursday morning with social distancing still in place. And then there's a plan to open the beaches on Monday morning, again, with social distancing in place. But there's a lot still hinging on the governor's order, which expires Thursday, and he's expected to announce his plan for next steps, I believe tomorrow is what we're hearing now. So a lot still depends on what he does, and a lot still remains to be seen about the virus itself. which is, I think, really gaining a reputation for being a difficult to deal with virus from a clinical standpoint, and very hard to pin down and anticipate necessarily what's going to happen with these patients, with lots of different presentations and lots of different clinical disease courses. Although, again, I think we're starting to get a better understanding. We still don't fully grasp this thing. We're still operating on theories, not proven case series or case control studies. So I think I will stop there for the update, unless anybody has any particular questions. And Peg, I sorry to hear you didn't like that music. Okay, Jasmine, who's up next?
Up next, we have our EPCR update.
Did we have specific questions from last time too, though? Are we doing an update or just a question?
We're going to do a little bit of an update, maybe to open the door for some questions. I feel like that would be a good start.
Okay.
Steve,
So-
you or me? Me. Got it. All right. So let's start by looking at a new signature type that was added. This impacts predominantly Sunstar because it's for transport. And previously, when you didn't want a patient touching your tablet, when you didn't want any kind of biocontamination to your tablet, you would do a type 5 crew signature and mark biohazard. And then from the receiving facility, you would get a nurse to sign a type 6. Now we combine both of those into a singular type 8. But before you can do this, you must have a good quality conversation with the patient. And by that, I mean that you need to say, sir, ma'am, may I sign the tablet on your behalf? It is stating that you want to go to the hospital, that we can bill your insurance company on your behalf. In order to bill them, we need to be able to send them information, and that if they don't pay, you'll be financially responsible. If you've got that in place, then you can sign a type 8. I encourage you very much, read the type 8 signature. Let's go in there ever so briefly, and boom. Here we go. Type 8 signature right here, EMS crew member. That's going to be, in this case, me. And next. And then let's make this larger. And so my signature indicates the patient was a confirmed COVID-19 patient, and that's confirmed or suspected, and that the patient gave verbal consent for evaluation, treatment, transport, permission to sign the patient care report on their behalf. It's laid out really simple, straightforward. Make sure that you have that truly in place before you use a type 8 signature. If you don't, just go old school and get a type 5 and type 6. Steve, anything else need to be said on that part? And
Not
do we
that
have
I'm
any
aware of.
questions?
Not that I'm aware of. The closed call rules will take care of that and make sure that it is a COVID patient and that you've documented the COVID patient correctly, which includes the standoff assessment and the secondary impression and the secondary chief complaint. Yes.
Good point. There's really solid closed call rules that cover you all the way through this. Jasmine, I'm not seeing any questions. Do you see anything I don't see?
No, I don't see any questions. We have a small group today. So,
Cool.
but the questions that I have had over the past 2 weeks were related to signatures. So with a refusal or with a transport signature, if the patient is not signing due to suspected COVID, then the update for that would be the biohazard, right?
Ah, yes. So let me share my screen again. Here we go. So if I'm signing a type 5 or a type 8, And the reason that the patient is unable to sign is biohazard right there. We used to have this years ago, it went away, and we brought it back with COVID-19.
All right, so to clarify, if you have any patient with suspected COVID symptoms and they're not signing your tablet, whether it is for a refusal or a transport, that is where you would go to click to confirm that.
Bingo.
I think that answers the question.
That's it.
Do we have a standoff assessment on code? Why do we have a standoff assessment on code 2s? So Dr. J, you may want to jump in on this. My quick understanding is, Dusty, this is something that we want to be doing on every single patient. And the standoff assessment makes your documentation just a little bit easier, saves you a couple of sentences in the narrative. Dr. J, anything else to add on that?
Yeah. The reason we have standoff assessments on every patient is to keep you safe, because there are asymptomatic people out there. There are people with unusual or atypical presentations. There are people who think they might be cured when they're not. So the reason we have the standoff assessment on every single person you come in contact with is the same reason why people are being asked to wear masks in the grocery store. You are having to approach and deal with a patient, and there is no reason why you should do that without taking a quick second to figure out whether that patient poses a risk based on being possibly contagious, and taking every precaution in addition to your baseline PPE. The bottom line is we have it on every patient to keep you all safe. Okay, so what else? Did we really answer all of the EPCR questions that we had from last week with 3 minutes from Ed? Is this possible? By the way, Ed, I have to congratulate you. That was like the possibly shortest, most concise explanation I've ever seen you give.
I don't know whether to say thank you or not.
Not as long-winded as usual.
All right, that's kind of like that's kind of like the guilty accusing the innocent for me to say that. All right, so there's a couple other questions from Dusty and Peg, it looks like, coming in.
So I believe when she said code 2, she's actually talking about interfacility transfers.
Right.
Okay, because
Yeah.
there's some terminology that's different. That's why I said that from the field to dispatch.
Sorts of stuff. I believe Dusty's talking about interfacilities. And in some cases, even BLS interfacility kind of stuff. And the answer, again, is out of an abundance of caution. We have not had, out of nearly 2,000 clinicians in this system over the course of 2 months, we have not had a single occupational exposure resulting in infection that we are aware of, and we would very much like to keep it that way. And that is why we do baseline PPE, and that is why we ask you to do the standoff assessment on every single patient, even if they're being discharged from the hospital. And I'm not sure if Peggy's talking about a particular call, but in any case, what other questions do we have? Steve, any other updates, data-wise, in field impressions, anything like that? We got all that covered?
Yeah, pretty much. The big changes are coming, but we'll go over those maybe on a different call that aren't related to COVID-19.
Okay. Hello, Dr. Smith.
Hi, how are you?
I'm fine. Have you been in the hospital recently, Dr. Smith?
Yes.
Work in COVID land the other day?
Yes, I did. And didn't have a single positive COVID case. It was everything but COVID.
Hey, that's fantastic. So there are definitely still COVID patients in the hospital, but it does seem as though the numbers coming in general, with the exception of from some congregate living or long-term care facilities, seem to be relatively small. The tidal wave that we were all afraid of never seems to have materialized, so that's good. Chief Magnus says, update on responder testing. I wish I had an update for you, Chief. Hopefully I'll have something by the Thursday. In fact, Dr. Smith and I are planning a call first thing tomorrow to try and see if we can't push things forward. But right now we appear to be stalled by the FDA. That's sort of where we're sitting. We're trying to find a couple of different strategies to get around that, but that is currently kind of our situation. Trying though, trying. What else? Jasmine, what else do we have to talk about?
From Thursday to today, I don't think we've had very many changes. We did put out a EPCR update reference on Target Solutions if anybody needs that.
Cool. My thoughts on beaches doing full. Are you asking me, Stephen, or are you asking somebody else here? I mean, I'll chime in, but it's a complicated decision, and I think what I said on the Board of County Commissioners this morning is my best take on it, which is that we asked the community to do some pretty extraordinary things over the last couple of weeks. We asked people to sacrifice a ton of their livelihoods, going to work, not having their children go to school, becoming overnight teachers, dealing with change after change after change to the way we ask people to live. And all of those things appear, we think, to have had some effect in staving off that overwhelming wave. Now, there's also a couple of studies out there that say, well, maybe that's would have happened this way either way, and that doesn't really, wasn't really effective. But I think most of us feel like that probably had some positive impact and bought us time, which is what it was really designed to do, was buy us some time. Now that we're into more of a slow burn instead of an overwhelming wave crashing, I think that we have to recognize that some of those things we've asked people to sacrifice are not sustainable in the long term. And we can't keep all of those restrictions or sacrifices in place. They're just not something that we could do from a long-term standpoint. And so every decision is in regards to what gets opened, how things go closer back to normal, I think needs to be made in recognition that if we feel as though the actions we took over the last couple of months had some impact, then we should expect that anything we do that undoes those actions will have some impact as well. And the question becomes, are we okay with that? Can we live with that? Is the alternative worse? Is the medicine worse than the disease? And when you think about the fact that we're probably going to be living with COVID for the next 3, 6, 9, or even 18 months or longer before there's, a definitive solution like a vaccine that's, been administered to 70+% of the population, which is sort of around the point at which we would expect transmission to really peter out. If that's the case, then we really have to learn how to live with this thing. And so each of those decisions about returning to some sense of normalcy or activities that we've asked people not to do or give up, those are tough risk-benefit decisions. And so could it have some impact? Yeah, it could have some impact, but exactly what impact remains to be seen, and it's a risk-benefit decision. So I think that the board was careful and deliberative, and I think the governor will weigh in with some more guidance shortly, and we'll see what happens. But it's I hope that everybody will maintain social distancing and do the best they can to return to some semblance of normalcy, while still doing what they can to prevent spread of infection. So I think it's possible. There may be some people who don't follow those guidelines, and frankly, there's probably already some people who are kind of tired of that. So, you know, I think it's about a balance. What else? Any tips or tricks for our patients who present as COVID with happy hypoxia? Does proning them show to work, or having the patient roll side to side? Yeah. So this is a great question. We're hearing a lot more about the concept of hypoxemia in these patients. And the reason they're becoming hypoxemic is that there's a dysfunction at the alveoli, and there's a VQ mismatch. So the alveoli are getting destroyed directly by the infection, and then there's a VQ mismatch with a lot of shunting of blood around the lungs. And so anything you can do to recruit more alveoli and decrease the shunting should have a positive effect on oxygenation and mitigating that hypoxemia. I am hearing some thought leaders out there talking about the term happy hypoxemia is probably one that we should find a better alternative for. When these patients do become hypoxic, although they may have minimal or no symptoms for a while, when they have actually, and those of you who've been through orientation know all about the cliff, okay? When they get to the cliff, even if they're not symptomatic yet because they got there really slowly, they are still about to fall off, and they are still about to fall off the cliff, and they are still about to really suffer some pretty darn bad mortality. Jasmine, hang on a second. I want to look at the CAD for a second. It looks like a plane just landed in the water near my house. So there's that. All right. I'll try and answer a couple more questions. Geez. So let's see. So we were talking about hypoxemia. So yeah, moving the patients around and recruiting could certainly help keep things, stave off some of that hypoxia. But by the time they get to this point, they're in a bad way, and we really shouldn't minimize it by calling it happy hypoxemia, maybe. Another one is, a couple of people say they feel like the call volume is increasing. I don't have the specific numbers on that. I do believe it is beginning to increase. And at least that's been my experience in the ER. Josh asked about a second stronger strain. We haven't seen a ton of mutation that would make me believe, but it's always a possibility that you get some shift there. Absolutely. Contact tracing is a tough deal, Jeff. There's people that are working on like apps and stuff, but that's a resource intensive process where you have to go out and go face to face with people a lot. Apps generally don't work too well for that, although some people are working on them. I know that the local DOH has done a lot to beef up their ability to do contact tracing here in the community. Josh says, in the 18-month scenario, will this just get us to a vaccine, or will this be an annual thing like flu that we deal with for years? Real question, real good question. One of the issues is that coronaviruses are notoriously difficult to make vaccines against to get lasting immunity. And previous efforts were not necessarily successful before funding ran out. So I believe there'll be enough funding for this one, but it may take longer. And the two options to get us to not having a lot of transmission are herd immunity, which relies on somebody being able to be infected and then recover with lasting immunity. That still remains to be definitively shown for this virus. There is certainly some reporting of people either getting reinfected or having reactivation of the virus a long period after their initial infection. So it's not clear that herd immunity is going to be all that useful to us. Even if that were the case, 60 to 70% of the population would need to be infected for us to get to that level. 60 to 70% of our population getting infected would potentially result in a lot of mortality. So given the fact that like something like a quarter of our population is over the age of 65. It's hard to know, Josh, but I hope that we get a vaccine sooner rather than later and put an end to this. And I hope that we learn a lot of lessons from this so that the next virus that comes out, we don't have to endure some of these sacrifices. Yes, there is certainly a concern about a second wave in the winter with seasonality. I think a lot of eyes are on the Southern Hemisphere right now with Australia, et cetera, and seeing what's happening down there as their season goes into a more colder season while we're going more warmer. So that remains to be seen whether we're going to get seasonality like this. But if you go back and look at just about every previous outbreak or pandemic over the last century, all of them have ended up with a second wave and seasonality as part of the event before it was finally done. Again, the antibody testing, we're trying to find a solution forward. The initial plan kind of got derailed by the FDA changing some guidance, but we will try to do that. Dr. Smith, can you come back on? Let's see. People want to know who you are, aside from Foghorn Leghorn. I do.
I appreciate that. So I'm Andrew Smith. I've had the pleasure of meeting you personally or speaking to you on the radio. I'm MD4. I'm the EMS fellow with Pinellas County EMS. So that's at the end of your residency, I'm doing a year of specialty training to learn how to work with medics and EMTs and all the different aspects from administration to field response. Have a lot of respect for all you guys and everything you do. Y'all are the real heroes in my mind. The stuff y'all see, when somebody's brought into the hospital, they have the nice, clean, pristine environment. It's totally different than a first responder. So I really wanted to work with everybody, and I'm excited. It's been about 10 months now, and I was fortunate enough that I will be staying on with Pinellas County EMS in July as one of the associate medical directors. So I look forward to meeting as many people as I can and working with y'all in any way that I can.
All right, thank you. So hopefully those of you might recognize his voice from the radio. He is currently MD4.
You might also recognize him from some of our CME videos.
That's
you watch those.
Didn't you try and put a chest tube in a SOCA medic in the trauma bay to show everybody where to put it or something?
Yes, I did. He was the only one that was thin enough and willing to take their scrub top off to make the video. So yeah, he worked out. He was very willing. Yeah, almost too willing, a little bit worrisome.
Well, those special operations guys are a little.
That is true, but hey, he was a big help. So yeah, if y'all ever want to talk about chest tubes, let me know. I'm always down.
Yeah, so that's MD4, Dr. Smith. A lot of you probably recognize his voice, the Alabama accent there that we know and love. And he will be, as he mentioned, staying on with us. So we're looking forward to having him as a permanent part of the team here when his fellowship is over in just 2 months. Should people who test positive for IgG donate plasma? Would that help in our area? Jeff asks. Yeah, Jeff, there's actually a way that you can do that. And I believe the link got sent out before about how you go do that. I will try to get the information. I have to dig it out of my email if it didn't go out, but actually TGH is actually assisting with a national study that's working on that, I believe. And I believe it said you could go to a TGH urgent care get screened, and then they would refer you to donate blood if the appropriate criteria were met. So, Jasmine, if you can remind me to send that information out or post it on Target or however we want to do it.
Yeah, we could do that.
Otherwise, I think you can just search for convalescent serum donation and you should find it. Chief Bessler asks, does turning 60 really triple his mortality rate? And yeah, it does. Sorry, Chief. For those of you who don't know, Chief Bessler had a birthday this week, and his mortality rate, given his new age and status as a senior, has certainly gone up. So happy birthday, Chief Bessler. I will try to pull up, while I'm trying not to laugh too hard, I will also try and pull up the, Steve, you got to say something so you come up on the screen when you do that. Jasmine has us in speaker view, I think, not gallery view, so they can only see who's talking.
Oh, I could change that. Don't worry. You want to see everybody?
Well, Steve just was funny.
Hey. All right, so I'll mention that you'll see some changes on Target Solution. We'll be releasing updates as packages change because there's a lot of shortages right now. So you'll see packaging changes come out pretty regularly over the next few weeks.
So let me just share this image real quick. Here you go, Chief. I think you can see here that the mortality rate definitely increases once you get into that age range that that you just achieved. So, yeah, evidence-based at that. Is the guy in the top right? Who's in the top right?
I think that's me.
This is the guy in the top right. Sorry, I lost sound. I don't know if you said anything.
Oh, in the comments, somebody said, "Is the guy in the top right the makeup guy?" Brett. I think. Oh, yeah, that's definitely Dr. Smith who was just talking. He's on a day off from the hospital and joining us from unpacking his new house. So I appreciate him taking a break from all the manual labor to join us.
I appreciate the excuse to stop doing manual labor.
But
yes, if anybody needs makeup, I can help you.
Oh God. Okay, so Pinellas Medic asks, how is our PPE supply, and do you think the P100s will last till this is all over? Our PPE supply right now, I think we're in better shape than we have been since this all started. So I just cannot say enough about our supply folks who have worked tirelessly, our emergency management folks who have gotten us stuff where they can, Pinellas Park for spearheading the mass decontamination process that they're doing. We honestly, I think, are in a pretty secure place right now. We need to obviously be judicious about how we use PPE, but we are sitting pretty well to be sustainable for the long term. We had a couple of real good breakthroughs in the last few days, and I'm very happy with what our numbers look like in terms of what we have in the warehouse. As far as the P100s, I know they're a bit of a pain in the butt. I saw a few patients while wearing one last week just to try it out since they were COVID rule outs anyway. And it is certainly a bit more difficult to communicate in, but it's definitely seems pretty safe. I know that a bunch of folks are working on alternatives, including using Scott Pack masks with voice amplifiers, or I guess there's some of them are MSA too, but and so that's a potential solution. I am a little worried about making sure that those masks last. We do have, I believe now, some backup in the warehouse, not a ton yet. But you do need to take care of those masks. Make sure that you're going to get as much use out of them as possible and not have the plastic break down or get contaminated or whatever else. So would I think we're doing okay, but I would say we still need to be cautious. So Tim says the P100 is way more comfortable than the N95 and goggles, which is funny because a lot of people think exactly the opposite. So I guess to each their own. But I'm just glad that we have enough PPE to go around right now, and that we can keep everybody safe, and we're not having to take shortcuts or use what's sometimes referred to as alternate PPE strategies, like pieces of cloth over our faces. So I'm happy that we're not doing that. I'm happy we have everything we need, but I would still ask for us to be judicious in how we use them. Another question on individual municipalities obtaining COVID tests and testing employees. I know that a few folks are doing it. And again, I would just refer them to the updated FDA guidance and some of those concerns, and make sure that they're doing everything appropriately. What else? Yeah, it's tough to hear with the P100s on, Dusty. I know. It's really funny on the other end of the radio when we're doing consults with the P100s because it's like what was it, like a Snoopy episode or something? So, all right, let's see. Fire away with any other questions that you guys have. I think I'd like to keep this Thursday's YouTube session at 3:00. And then next week, I think I'd like to on Tuesday make a decision about ongoing frequency. So I'd like to ask the group whether they'd like them to continue at twice a week, whether they'd like to do once a week, as we get into this being a more long-term kind of a process.
Also, is there anybody you'd like to see up here that you could ask questions to?
Oh, that's, yeah. Any word on when medic capstones will resume? They didn't stop, did they?
No.
No, they didn't stop. We kept the pipeline of new medics going with social distancing and precautions in place because we wanted to make sure we had enough folks to get us through this. Nellis Medic says, if we continue to have outbreaks in nursing homes, would this lead to a category red, and do you see us staying at yellow for the remainder of the virus? So I certainly hope we stay at yellow for the remainder. I think it's still possible that we could see category red at some point, whether that's later this spring, over the summer, or next winter. I don't know. So much remains to be seen here, that I really can't predict that. I think it's good we're ready for that should we need it. But I think right now, certainly our level of resource utilization is not such that we need to be at a category red. So I certainly hope we never get past yellow, but I don't have a crystal ball. Michael says, are we supposed to be putting a surgical mask or N95 on every patient and not just those that are suspected or confirmed COVID? Well, I don't think we're putting N95s on any patients because N95 is a respirator that you need to be fit tested for. So we would be putting a surgical or procedure mask on the patient. Jasmine, what do you think?
Surgical mask on suspected COVID patients or family riders.
Yeah. So you need to have your baseline PPE on every single patient contact. And then I would add a mask to the patient, which is, again, about protecting their level of secretions out. So the surgical masks generally protect things from getting out from the patient, whereas your mask protects you from getting things in. So on every patient, you want to be protected from getting things in, but if you think that there might be a reason to suspect COVID, or you're doing something aerosolizing or anything like that, then you would want to take those additional precautions. So you're sort of doubly blocked. You're blocked from it coming out from them, and you're blocked from it coming into you.
So I think it's important to mention that as things open up in the community that we are not changing what we are doing, and we are still yellow, and we're going to continue our PPE use as we have been.
Yeah, that's a great point, because even though the curve may be sort of flattening, and again, that's still sort of early on that, but that's the indication, the early indication of where we're going. That does not mean that there's not new cases. People are still getting infected. People are still being hospitalized. Oh, Dr. Smith, you're going to steal the show. And
Bother me. She won't go away. Good job.
that's social distancing, Dr. Smith. Yeah, people are still getting infected. People are still being hospitalized, and people are still dying. And I think we need to keep that in mind. We also need to keep in mind that we really don't know what the overall level of positivity of the virus out there in the community is. So, stay cautious, stay protective. Tim suggests holding the mic up to the exhaust port on the bottom of the P100, and you can hear better. I think that's true. Tim also asked thoughts on FD medics wearing shorts with isolation PPE. I think we covered that a long time ago, but that's probably going to be an agency uniform decision. Dusty asked about facilities putting patients in 14-day isolation after returning from the hospital. Hopefully they're not quarantining those folks in the same area with active cases if those folks are already negative. There's a lot of discussion going on right now about how to safely discharge people from the hospital following infection. So there's an active, in fact, my next call is about that in 45 minutes from now. So still an area of debate to find the best, safest solution there. Jeff asked about, so I think in general, we're being less aggressive about tubing these folks. Clearly in the beginning, the guidance was if they drop their SAT, early and aggressively intubate them. And then we had all these people who were texting on their cell phones and not really that symptomatic, who had terrible numbers. And people started figuring out that they do better if you can limp them along on supplemental oxygen and or BiPAP, as opposed to intubating and paralyzing them. So yeah, in general, I believe the practice is shifting, and that may be part of the reason we're seeing a bit lower mortality rate in the United States than Italy. One reason. I think there's several reasons on that. But. Okay, what else you guys got? Nobody answered the question of how often they want us to keep doing these things and who else they want to hear from. All right, so I got one vote for keeping it 2 times a week for a little bit longer and then maybe backing it off to once a week. That's one person out of 2,000. Do we have a therapist that we might be interested in hearing from? Yeah, we could probably find an RT to come on. See, I told you, more of MD4's dog. Now you're going to have to come on every week, Dr. Smith.
I'll just put her on.
Okay, so the consensus seems to be like once a week. So let's continue this Thursday. We'll finish out this week. We'll do Tuesday, and then we'll reassess at that point. It seems like more people are saying once a week than twice a week, but we can just adjust it as need be depending on the situation, I suppose.
We only have 22 in this group. So if you're watching this on Target Solutions later, you can always shoot me an email. It's at jsolomon@pinellascounty.org if you want to let us know what you want to see on here.
There's 88 on the YouTube.
Oh, I have 22 on my screen. Maybe I'm wrong. Oh, I see that. My screens don't match.
Uh-oh.
A lot of technical difficulties over here.
Yeah. We're all
30
getting...
seconds behind.
I like the 85 better than the 22, so let's go with that.
Yeah.
30 seconds behind.
Okay, so I have a question from test 1 2 3. That's pretty funny. Are you seeing more people coming into the hospital on their own or by EMS with suspected COVID-19? That's a good question. Dr. Smith, when you were in COVID land last week doing the COVID specific ER unit, most people coming ambulance or most people coming POV? My take is POV, but what do you think?
I think it's more POV, especially the walking well, the people that are just have, vague symptoms, maybe a subjective fever. They come in, they get a test, and they go home, wait on the results. The people that are actually sick, the ones in respiratory distress, they're more coming per ambulance. So I'd say overall, more per personal vehicle, but I would say the sicker ones are definitely coming in via EMS.
Makes sense. All right, what other questions do you guys have? Got a few minutes before I need to hop off and go to the next thing. So it seems like we answered the EPCR question. I believe we've pretty much gotten everybody on the same page with the PPE thing. I think we've covered most of the treatment strategies for dealing with COVID patients. And I'm not sure, we update the epidemiology every time. So I guess my other question is, aside from the one suggestion from an RT, what other topics would you like us to address in the next one or two of these things? What other questions? Are there more thoughts given to the virus not liking hot or humid versus cold? Again, we're historically, we would expect to see seasonality. We would expect the heat and the ultraviolet rays to disrupt the virus envelope and therefore inactivate the virus. That's why flu season is not the summertime generally. Also, people are less sort of crowded inside places in the summer. So historically, we would expect that. I don't think that we have definitive evidence of that on this virus yet, and this virus has fooled us a couple times already. So there was a report you saw from the White House. There was some data that they showed on it, but the caveat on the bottom of that is that that report has not yet been peer reviewed, and it has not yet been through the entire process. Henderson says, how are you treating confirmed COVID patients in the hospital setting? Dr. Smith, you want to chime in on that one?
It's pretty much supportive care, supplemental oxygen, BiPAP, high flow nasal cannula, IV fluids, Tylenol. Not a whole lot we can do. I mean, there's still debate on the hydroxychloroquine or Plaquenil, azithromycin. So those are all things that are being actively studied at a lot of big academic centers right now. And hopefully we'll have some better guidance coming out soon.
I think the other thing we're doing is looking for a inflammatory surge. So a lot of these patients have, as a marker of when they're going from mild disease to severe disease, they have a sort of overly enthusiastic inflammatory response in the lungs. So we're looking at things like dimers, things like lactates, things like procalcitonin levels, all sorts of inflammatory markers that we normally use for other disease processes. We're seeing significant abnormalities in those, and that can be an indication of when somebody's going to take the turn for the worse, even if they're not symptomatic yet.
Mm-hmm.
Oh, there's a really good clarification point there for Riley. So it does say, but it doesn't actually say not to treat it. It's that we will accept a SAT as low as 85 without going to airway management and stuff. So that's what that means by permissive hypoxia. It's not that we would say that's our goal. We'll say we will tolerate it being down to 85 before we start to think more about things like airway management. So in a normal patient, if you couldn't get their SAT above 82 or 83, you'd be thinking really hard about I should be intubating or dealing with the airway on this patient to help them oxygenate and ventilate. But in these patients, we'll tolerate that for the pre-hospital interval to make sure that we can do all that stuff in the safest manner and potentially nurse them through. We'll see how they go in the hospital. Excuse me. Dusty, I'm not sure. Oh, yeah, I see what you're saying. So I don't know about a gown yet. I know that the ideal from a comfort standpoint would be a PAPR, but we don't have a lot of PAPRs. Those are the ones that blow a fan on your face with the positive pressure from the filter pack that hangs around your waist. Those are certainly much more comfortable than N95s or P100s, but they are also very difficult to get right now. Jeff asked, do we know how many times or how quickly the virus has mutated? So I think I showed a graphic a couple times ago in one of the videos with the big sort of star pattern of the mutations of this virus. There's large mutations and small mutations, and not all of them are clinically significant. But in general, there seems to be sort of two clusters is what people were thinking. I think that has evolved a little bit, and instead of thinking it as two genotypes of the virus, I think people are thinking of those two clusters, the L and the H, as more of two, what we would refer to as a phenotype of expression or clinical picture of the virus, and that those two now are even more being considered as a spectrum of disease where you go from compliant lungs without ARDS to non-compliant lungs with ARDS, going from the L to the H. Whereas I'm not sure that the actual genetics behind that matches up with those particular clinical presentations as was previously thought. Again, there's a lot we don't know about this virus, still a lot. Michelle asked a great question. Have either of you seen the reported increase in stroke in the younger population? Have you seen this, Dr. Smith?
I personally have not, but I know that it is an increased risk. And so I would just encourage everybody to be, more cognizant of this. If you see somebody with stroke-like symptoms, but they're in their 30s, a lot of times we think, oh, maybe they're drunk or they're on drugs, but always have that in the back of your mind, because this is, one of those things that we can intervene on, and it definitely does increase risk for stroke.
Yeah, it's really interesting. There's been some discussion about empirically anticoagulating these patients, whether they get a very aggressive prothrombotic state during infection. There was even, I think, a couple of sort of case reports of people using thrombolytics on some of these patients. And then just as much discussion actually on the other side about maybe they're on the other side of the spectrum. So I don't think we know. I've seen those reports, but I've seen also reports of things going the other way with like DIC kind of stuff. So again, remains to be seen. We are just learning about this virus every day. And so what we think today based on our sort of recent experience may very well be the opposite next week. Tough to know when we're in an absence of randomized controlled trials and other types of harder evidence beyond experience.
Mm-hmm.
Those are some really great questions. What else do you guys have? Nobody asked any more questions. I'm going to play some more of that crap music that Peggy liked. All right. Well, I don't see anything more coming. So Jasmine, any other things that we need to cover? Any other thoughts, concerns?
I don't think so right now. I think we'll have a little bit more to talk about on Thursday. So just tune in then.
Yeah, we keep it 3 o'clock on Thursday, right?
Yep. 1500 Thursday.
1500 on Thursday. All right. Last chance for any questions. Throw them up there. Ed or Steve, did you guys have anything else to add, or are you even still there?
No, I'm good. Thanks.
Ed, you're good?
Thanks.
Okay. Thank you guys for joining us and clarifying those questions. Dr. Smith, anything else you want to add?
Nope. Appreciate you having me.
All right. Well, I think I've called long enough, given them a chance to put anything more in the comments, and I don't see it. So I think with that, we'll go ahead and end. Kept it just under an hour, and we will see everybody back Thursday at 1500.
All right. Stay safe out there. We'll see you Thursday.